Hi everyone, thanks for joining. We're going to get started now. Just a reminder, 30 minutes, one question, one follow-up. And today we have Dr. Williams and Dr. Allen here, so I'll turn it over to them for some brief remarks.
Right, well thank you, and good afternoon. It's Monday, so our talk today is about what happened over the weekend. And I'm pleased to say that we want to make sure that people had a healthy weekend. They stayed home and stayed safe. There's evidence that seems to be indicating people are attempting and working hard at that. So I do applaud everyone who is doing what they need to do and do it again. And we're going to be talking about reasons why that's even more important now. I'm pleased to be joined today by Dr. Vanessa Allen, who is a medical microbiologist and the Chief of Microbiology and Laboratory Science at Public Health Ontario Laboratory. I'm going to ask her to give some updates on the whole issue of variants, and you've heard lots of talk about that, including the ones, and she's going to allude to those different ones that are there. And so we're trying to give you an update on that information and what in Ontario are we doing in regards to assessing the presence of the variants in our jurisdictions and then taking steps and actions accordingly. Also, besides Monday, it is the one-year anniversary of when a year ago, an evening, not on a week Monday, but it was a Saturday, and I'll be talking about that after Dr. Allen gives her updates. So let's talk about what we've done since Thursday. Thursday we saw 9,396 cases of COVID-19, and a total, unfortunately, of 232 people have lost their lives in that time. And this is the ongoing concern and issue that's very disheartening for us, and we want to keep working at that, and that's why we have our vaccine program going, our detailed testing, and different things we're doing in different sectors, trying to work at that as aggressively as we can. If we look at the same period a week ago, we reported 12,054, so we're down at that time, and even before that we were at 14,975. So you can see we're coming down, and our data is very much indicating that. Our 7-day average is currently 2,371. That's January 19 to 25, down from 3,056 the week before and 3,555 on the day weekly before that. Today we're down to actually 1,958. So that's our first time truly under 2,000 since December 13th. We had a couple of days we due to data reporting, we jumped down. That was not quite accurate. So they were nice to see at that time, but we knew we rebounded, and that was a different story then. Our outbreaks are 28 today. That's slightly lower than they were last Monday at 31. And our 7-day count for outbreaks is showing some stabilization, and we're hopefully going to begin seeing a reduction in those numbers as we go along. So we keep seeing these numbers coming down steadily, and we see the impact of the lockdown on Boxing Day, and now we have the further impact of the stay-at-home, which now we're going to start to see some evidence of that as we go into 10, 12, and 13 days after that took effect. And so we're going to watch and see what happens there. But as I said, a lot of the health units, their numbers per 100,000 are coming down pretty well across the board. There's a few sort of plateau and leveling, but it tells us that we're going in the right direction, that you're doing the right thing you need to do. Except we got to do it a lot and keep at it, and we're going to hear in a moment why we even have to be more careful and cautious in the presence of variants in and around our communities, as Dr. Allen will update us on that shortly. We're still seeing high numbers of deaths, and we told you before, and as Dr. Brown with his modeling, that these hospitalizations, ICU admissions, and deaths are late indicators that come on. So they are deferred until a period of time. So we hope that by our numbers coming down, we're going to see less people being admitted to the hospital in general, which we're seeing a bit of. The ICU numbers have not dropped extensively, but that will take a while for them to start to drop. We're still over 400. And we also then would like to see the deaths start to drop. But first we see the drop in the number of residents that are positive or are considered active. And we're starting to see that for the last number of days as they start to drop too. So these are all similar to what we experienced in the first wave, but these are the early days of it, all looking promising and looking encouraging. So we also at this time we're trying to also extend the condolences to our COVID-19. It's a year, and we've had now 5,846 people who have died with COVID or from COVID, both, and to extend our condolences to the families and members on that, as we've all struggled through this for the whole year, and we continue to persevere and work at it. As I said, it seems that in the second wave, as you do your part, we're having some evidence of success in this way. So right now, because we're hearing a lot about the variants, and I'll have a few comments to make afterwards, and then about the anniversary, I'm going to ask Dr. Allen to talk about what are we doing in Ontario in relationship to the so-called mutation variants, and some information on that. So over to Dr. Allen. Thank you.
Thank you very much, Dr. Williams. So what I would like to start with is just a little bit of a descriptor of these variants of concern. As background, all organisms, as all of you are aware, do mutate at a certain frequency. In some ways, luckily, COVID-19 actually does not mutate very rapidly compared to some organisms. But what we have seen of late are some strains of COVID-19 that actually have a higher rate of mutation. And these are, in fact, called variants. And so these variants differ significantly from the founding strain that was identified in Wuhan. A variant of concern is where not only does the sample show an organism with more mutations than is expected, but also that has evidence of either clinical or public health significance. So specifically in the case of the UK variant, there is some initial data that suggests that it's both more transmissible, that was described by Dr. Brown in his earlier presentation, and now there is more recent evidence to suggest that it might cause more severe disease in some individuals. There are three primary variants of concern that are being followed internationally. These variants include the UK variant, which I just described, and it has been identified in over 60 countries across the world. There is also the South African variant that has a slightly different range of mutations in it. And then lastly, a variant that was identified in Brazil, the Brazilian P1 variant, that also has mutations of concern. With respect to what we have identified in Ontario to date, 34 cases of the UK variant have been confirmed in Ontario. That we have identified no variants of the South African lineage and none of the Brazilian P1 lineage to date. With respect to what is being done currently to both detect and respond to the potential of these variants, it is very much an integrated response across clinical, public health, and research organizations to rapidly identify these variants and to link them with public health management. Specifically, there is a baseline program with many collaborators that include the Ontario Genomics Consortium that have been sequencing since the beginning of the pandemic, and the initial analysis of samples all the way up until early December had shown no variants at that time. To complement this baseline capacity, PHO has introduced a screening test that looks for one of the mutations that is in all three of these variants. The program now is to identify high-risk samples using this screening test so that we can get initial results quickly, while the whole genome sequencing, which is the second stage of testing, is performed to confirm this, but because it is a longer test, an earlier signal can be provided to the system. Who is offered these tests? Currently, the screening test is performed in several different scenarios. So the first one is it's performed in any sample that comes from a known traveler that is COVID positive. The second set of samples that are screened for the variant include those in outbreaks, particularly outbreaks that are considered to be behaving in a more aggressive fashion, otherwise called a super spreader event. And then lastly, the main high-risk scenario is individuals who have been identified with having a characteristic pattern on one of the tests that is used in 3 of the laboratories in Ontario, the TACPath test, where one of the genes does not amplify or is not detected of that test. In addition to this, we're also performing a point prevalence study. So all of the samples that were detected positive on January the 20th have been sent and are continue to be sent to Public Health Ontario to ensure that we have an immediate snapshot of the prevalence of variants in Ontario. And then lastly, we continue baseline surveillance using whole genome sequencing across the laboratory system, and including research labs, to ensure that we detect early variants if and when they may emerge. And then lastly, critical to this is the testing needs to be tied very tightly to the public health measures, and so we are working very closely with our public health colleagues, including the public health units, to ensure that these individuals that are identified with a variant of concern are prioritized for case and contact management and other supports. So with that, I'll pass it back to Dr. Williams. Thank you.
And thank you, Dr. Allen. And I know she doesn't want to be boasting that, but our Public Health Ontario laboratory is the first one in Canada to develop this methodology with their genetics team, and has agreed to share it with the National Medical Laboratory in Winnipeg. And with that, we're one of the few jurisdictions that can go ahead with this very much assertive screening and testing to look for the variants in general, and then to get more detailed down to the genomic sequencing. So this is a step forward. I think as a result, we're going to see our numbers go ahead of some other jurisdictions who haven't had the capacity yet to do this. They may actually have cases. It's just we hope we can hope the technology gets utilized in wider sectors and could assist them to get advance notice of that. So very important, and the key issue there is that with the aggressive nature of the UK variant in particular, and it's now in our presence among our different health units, the reasons for being cautious, the reasons for being careful about masking, distancing, even with what we're doing here in the press conference, has to be enhanced even further, because it can be spread with breaches to those protocols in a very short period of time. So people who thought were being a bit casual, it didn't really matter a little bit for a short period of time, that's a wrong conclusion. And so we're going to have to be on our guard, but the same measures that protect you from the other strain of COVID-19 will protect this one, but you have to do it consistently and take cautions and precautions accordingly. Before I hand over to the media for questions, I was asked to reflect on a year, what a difference it makes. And I was asked, and I was reflecting on a year ago on the 25th, it was a Saturday, and upstairs we're walking to the press conference room on a dark wintry night in January. It was actually a cold winter than this one so far. And as I went down there, I was reflecting on 3 things. One was the confluence of events, the amount of collaboration that was already occurring, and the uncharted areas that we were moving into and the unknown at that time. And I remember having Dr. Barbara Yaffe with me at the table, and how we had gone through together other major events in the past and learning from those experiences: SARS, Legionellosis, the H1N1, and along with the evolution that we had been going through for the last number of weeks as we participated in federal, provincial, territorial committee meetings, and as we watched the fish market outbreak, supposedly, and a viral spread in China in a place that we didn't know too much about, namely Wuhan, that we would learn more about in the weeks to come. My mind was already turned to protocols and patterns that were already in play, and always wondering what we would learn and have to know as it advanced, as we had in the past with this new viral variant. Would it really result in a pandemic or not? Because we'd had many other ones similar in previous ones that didn't amount to that. Also, the collaboration. Unlike in the past, where sometimes we just have 1 or 2 people at the podium, we had a table with 7. And I remember that represented why we started wide with collaboration. We had the head of the hospital, the acute care hospital. We had the head of the ICU person who was looking after the patient. I had Dr. Yaffe with me. We had Dr. Donnelly, who was the head of PHO, so we had Public Health Ontario at the table. We also had Minister Elliott at the table in that, and so we had our wide representation there, and local public health with Dr. DeVilla was at the table. That showed how we want to collaborate. Even if we only had one microphone to pass among each other, and I was very concerned that we'd spill the water on the tables, but we worked well together in that time. And then how is it going to go from that time and on there with our events that occurred over that period? Who knew that now, a year later, we're still striving with new issues, new variants, and ever learning, ever shifting, ever changing. And that's what you deal with in a pandemic. There's things unknown. You build on what you do know, and you try to delve further into what you don't know to get better answers for. Evidence-based, not just conjecture and hypothesis only. You got to look for the evidence that gives you and supports those directions in the future. So here we are, vaccine rolling out, still early, getting going. And so that's the hope on the horizon. That's the difference we face now, a year later, where we said we might not, some said we won't get one till 2022. Well, we have one in 2021 and two in 21 and more to come. So that's where we are now. 1 year later, a lot of work by many different sectors, government-wide, from the Premier to the Minister to ministers, all the way through. It's been a remarkable endeavor by everybody to put all effort into it, and by you, the Ontarians and others, people of the media, to keep the messaging going and stay to the task at hand and realize the successes we've gained. But now we're ready for the challenge ahead of us. We got to hold the line for now with these new variants on the horizon until we get our vaccines fully coming and fully rolled out with General Hillier. So stay to the task, stay tuned, stay at it, and I know we can overcome this one as well as we did with the first wave. So with that, I'm going to hand things over to the media for questions.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
First question from Mike Crawley at CBC News.
Yeah, I wanted to ask about the variant. In recent days, several European countries have mandated that people wear medical-grade masks in indoor public places rather than cloth masks, because they're saying that cloth masks are not as effective at stopping the spread of these more contagious variants. Is that something that you're considering recommending in Ontario? Wondering in particular any other measures that would be effective at slowing the spread. Should the borders be closed to visitors from other countries? Should there be more restrictions on the contact people are having, given that the variants are spreading in Ontario?
Well, thank you, Mike. Those are all important points, and we're addressing those as we learn about the epidemiology and transmission. We are assessing that the wearing a mask is one thing, wearing it properly is another thing. It doesn't negate the need for distancing. We've said that before, and we said it again. It doesn't mean if you put on a mask, you can have a face-to-face conversation with someone for 5, 10, 15 minutes. In the past, you might have got away with the COVID for a few minutes. You will probably not get away with that with the new variant, the UK in particular. So we're asking that. We have the different layer masking that's going to be brought in there. We haven't yet had our science group recommend going to surgical masking for the general public in general, just because sometimes we ask those are for people we're looking at one, our healthcare people already have to work in close proximity to the patients, so you can't do the social distancing. We're looking at long-term care and retirement home staff, as well as looking at the essential visitors who may have to be in close proximity. So we're looking at those who, for essential reasons, cannot maintain the distancing, and those ones already we recommended that they have proper masking and potentially some facial shields, etc., to assist in doing that. So we will be reviewing that. I'm glad you mentioned the point about travel. I know the Premier has spoken again, as we've spoken all along. We really want to have much more stringent testing and isolation and quarantine of people traveling, because where it's coming from is getting wider and wider around the world. Even though it's called UK, it doesn't mean people just come from the UK. So we have to be aware of that and put those checks and balances in place, as you're hearing with many countries, and we've got to think how we can do it more stringently. So all good points, Mike, and things we have to keep ramping up and ensuring we're doing it again, doing well, and advising the public on any new science that's evolving to address these issues.
Follow-up?
On another topic, my colleague Nicole Ireland is doing a story about the rapid testing, and we understand that the province has 4.4 million rapid tests on hand, but has only deployed about 650,000. Why have you deployed so few of the rapid tests, and are there any plans to use rapid tests for when larger numbers of students are returning to school in the hotspot areas?
Yes, well, thank you for that question. And the answer is that we really wanted to have a good stock of the rapid tests. We have been continually getting advised by Dr. Allen and her team and our test panel on the strengths and weaknesses of the various antigen tests that are there, including the PanBio, which is the one you're quoting. We know it is not a diagnostic test per se. It is, and we're trying to look at how would we utilize it as a screening test. If we carried it out, in order to do that, we have to do a number of things. We've been waiting for the time to make sure that we can switch it from being a nasopharyngeal swab to a lower nasal, which was going to be an impediment to do wide screening. We want to make it easily accessible, and people would partake in it on a regular basis, because screening you do frequently, and some people, after having a few NP swabs, are not so eager to have another NP swab. The NP swab is still the preferable gold standard method for diagnosis, as Dr. Allen probably commented in a moment on. I'll ask her to comment on rapid testing, but at the same time, we want to make it that people would be willing to have it again, and have it frequently if they need to. That was one aspect. Who can administer the tests? So we've had to look at our regulations to make it more wide and variable, because we only have so many regulated health professionals to go around in this time of all the challenges they're facing with HHR issues in different settings at different times. So we've been doing some regulation changes to get that out there. Then if you're going to run a screening program, you can't do it in a scattered way. You have to put out a program of screening, because if you're going to do that, you have to make sure the documentation's correct, you have to make sure the recording's correct, the follow-up's correct, and the advice is correct, including the screening questions, etc. So it is a tool to be used in screening, not just on its own without that. And so these things have to be put in so that if it does take off and be used, especially if you're talking about school, you better have more than 4 million, because you will go through it fairly quickly if it's being done in a way, because we got workplace, we got travel, we got different things all over the place that we want to roll it out into. And also it's going to the long-term care homes. They're rolling that out. We're looking at how we might use it in retirement homes. So there's going to be a huge demand. So that 4 million may seem like a lot, but once those programs start rolling, it's going to get taken up pretty quickly in that. But we want to make sure we can document it and have it in a system rather than unstructured, unrecorded, and undocumented. We need to be careful and make sure we know what we're doing. It is a screen as an adjunct to a testing methodology, and that testing methodology assists, as Dr. Allen will talk about now, how that fits into looking for mutations in a timely way. So I'm going to hand things over to Dr. Allen to make a few comments about the testing procedures.
Thank you very much, Dr. Williams. I think you've summarized most of it. I think there's been some incredible collaboration across various different sectors to really figure out the pragmatics of how to deploy this most effectively. So it has included collaborations with long-term care, with other sectors, including various different industry partners. And so I think we are in a very good place for the deployment. The practicalities of the nasopharyngeal swab was an impediment initially, and there was a lot of work done again throughout the system to both validate alternative methods and then embark on the Health Canada approved PanBio test that was just recently approved. So I think more to follow, and it's really figuring out what is the best frequency for the deployment as an additional adjunct to the other testing armamentarium that we have in Ontario. So thank you.
Next question.
From Colin DeMello at CTV News. Please go ahead.
Hey, good afternoon, Dr. Williams. I'm just wondering about the current state of emergency, lockdown, et cetera. It seems like our numbers are starting to come down, and I know that there's going to be a trail of hospitalizations and deaths related to this. But I'm curious as to what you're thinking for the current lockdown. Should businesses be preparing for that eventuality when they're going to be reopening in early February, or is it still too early to say? Could it be perhaps extended once more?
So thank you. It's a good question. I will say that the number is down today. I think it may be, again, down around this range tomorrow. We'll have to wait and see. I think one thing we have to be cautious about is these tests now are coming into our weekend dip in volumes. So as a result, and because we're moving more tests out of our system into the Pan Bio one with the long-term care, so we're going to see some fluctuations in the numbers of tests as we hand off one to the other and then take on more responsibility. So we balance it out, because in last few weeks we were heading close over mid 75,000 tests being done, pushing to our limit, and we want to make sure we had some reserve before we do some shuffling and shifting. So while the numbers may be encouraging, I want to put them in a little grain of salt. We have to look at the trending to make sure we're there. I'm optimistic too. So before we start opening up the doors wide, that's why we had Dr. Allen speak today about the variant. And as you saw in the modeling table, the variant has a different challenge to us. How long has it been around in Ontario? How much has been moving? We saw, of course, that the outbreak at the long-term care facility in Barrie, that was going back to early in January. So our sense was, back with Dr. Yaffe, and I said before, it's probably been moving around in Ontario before that. We're now becoming aware of it. We may find out more as we do our assertive testing, and it may be more prevalent than we think. At the same time, it may be that our timing of our lockdowns was fortuitous as the UK spread was coming in, and may be holding it at bay. Therefore, we don't want to be casual and careless about opening up too soon. At the same time, we're concerned, and how if we did open up some things, we have to think way down the road, how can we do it in a safe and careful way? Because as we said all along, there's the benefits of lockdown, but there are consequences of lockdown, and we're trying to do that, maintain the safety. And of course, our big challenge right now is how do we deal with our schools? And of course, that's one date you're heading towards, is the 10th of February, and we're doing lots of discussion at this time how, with the Ministry of Education, to ramp up our surveillance systems to make sure if there is anything coming to schools, we pick it up early and stop it from getting into there and becoming a source of outbreaks in our schools, as that's what we're determined to do, much like we did in the fall.
Follow-up?
Thank you. And on this one-year anniversary, I'm wondering if we could look back for a second. Dr. Williams, could you reflect on the things you would have personally done sooner to reduce the prevalence of the disease in Ontario, whether it was masking, long-term care home directives, earlier lockdowns to deal with the second wave? What would you have changed? I mean, hindsight is 2020, as is the year, but what would you have changed if you were able to?
Well, I would have liked to have more information sooner, and that was the main thing, is that as we go through it, we kept changing with the data and information. That's part of a good pandemic response. You're advised by the science, you're advised by its shifting epidemiology. And as we're seeing now, as we just talked about, at the start, we didn't say, and we're going to plan for the unique variant that's coming up. We knew that there could be, and that's why Dr. Allen and her team and the consortium have been testing throughout, looking to say, is it changing? Is it shifting? Once it changes, then we're going to change some recommendations. So why didn't we change that before? Because we didn't have the information before. So I always would like information sooner. The more information, the better. The more science, the better. But as compared to SARS, we were light years ahead of what we had to face back then. And for those of us who remember back then, it was painstakingly slow. And we had to work most of the time in the dark of not having a laboratory test. We weren't sure of the organism, let alone genomic sequencing. So this is a new era for us. So while I would always have liked to move quicker and have the evidence come sooner, part of that is just the way the science and evidence comes forward in that. As I said all along, my challenge has always been to listen as much as I can to all the recommendations coming in and to be as up to date as possible, working in concert with all our sector here in Ontario, but more also importantly with our FPT partners, fellow CMHs across the country, as well as with Dr. Theresa Tam, and in concert with the WHO. So we would like the information to move faster, quicker, sooner. That's always what I would have liked. And of course, I would like to have a vaccine even sooner. But I'm surprised it's here now. And that's great. People were a lot more negative. But we want to have more and more vaccine. The sooner the better. Always pushing harder for get these answers as quick as we can. So, yeah, retrospectively, I'm always impatient to get the data more sooner, more quicker, but it has to be qualified. It has to be peer reviewed.
Last question.
from John McGrath at TVO. Please go ahead.
Good afternoon, and my question is about that question of data. When in the early weeks of the pandemic, there was a lot of debate about whether we were seeing community spread, and we had multiple conflicting opinions from local public health officers versus Dr. Williams and Dr. Yaffe. And now we're talking about variants, and I'm wondering how confident are you that you have a good sense of where these variants are and to what extent, or are we back in the dark again?
Right. Yeah, and I think when we were talking back then, as we saw the cases, we were very much trying to keep the case contact management with people with travel history and circling around those ones to contain it. When you say you have community widespread, you start to move in the territory that we no longer have a case contact management perspective. And we've seen that evidence in our framework, as you have watched. Once we get over a certain amount per 100,000, we start to lose that capability, and people start to have enough casual contacts, they no longer can recall what they wear. And so we lose that tool and that methodology. So when we do that, we have to switch our strategies. What we're saying now with the mutation, because we still have high numbers, we still haven't got the case contact management down to that limitation where we're controlling every outbreak. But at the same time, we can't wait for that. We have to put this information out. We're giving it out to health units. We're telling them that they have variants. They're going to go out and follow those up and saying, were they travel related? Do they know where they got it from, or they don't? And they may say, much like the other one, saying they have no recollection of any travel. They have no recollection of contact with anyone with any travel either. Then we know we have more information that we have community spread, because people are saying, I just got it. I don't know where I got it from. That means we can't do the case contact management, and we have to understand that. So we're getting this out as soon as we can, notifying all the health units. They're doing their follow-up. You've heard some announcements, I think, from Toronto today, from London. They're following up on theirs to say, what do you know? And can you rule in or out that it is travel-related, or is it community spread? And as we do more and more testing, we may say, and it looks like more and more of that. And that's our concern that Dr. Yaffe and I were talking about almost a week and a half ago. We were concerned already it was community spread, was happening. And now that the technology is progressing and catching up with us, we'll be informed better, but we'll be as concerned as we have been. And we need to all be concerned about that. And that's why we need to be stringent on our precautions and steps to take with advice that we're going to keep giving you and updating you as soon as we can with as much information as we can give you.
Follow up, and this is the last question.
I appreciate all that, and I guess, and I'd like to hear Dr. Allen's input on this as well. My question is whether, since we know that there are cases out there and they are showing up in places where we are not expecting them, or where we aren't looking for them necessarily, without wanting to be, really alarmist or whatever, but is it in fact just out there now, and are we not actually going to? Is it impossible at this point to control the spread of the UK variant, at least?
Okay, I will ask Dr. Allen to comment, and I'll follow up with a final comment on that. So over to Dr. Allen.
Great. Thank you very much. I think to Dr. Williams' point, we don't know yet, but we will be finding out in the days to come. And what we're doing is both integrating whatever results we have now to public health action while we gather more information in real time. So I think it's really in the days to week that we will have a lot more information, and at the same time we're increasing our overall capacity both to do the screening test and the whole genome sequencing. The goal based on the data right now is to do everything we can to contain every single case we find and increase our capacity to find them, recognizing that we still don't have the full picture because we have not tested everybody to date.
Yeah, and I would add, John, that we were aware that the UK variant's been around for a while. We probably assumed it was coming into our province back in December. We had identified some cases already back then. They were already in our community. If that was the case, and looking at Dr. Brown's modeling, if we are really concerned in that, and that's why we put in, I said fortuitously, the lockdown and then the stay at home. if you put those projections, we should be having 8,000 to 9,000 cases a day. Because you watch the UK and the Ireland rendition, it just took off exponentially. We haven't seen that yet. That gives me some reassurance that our measures are holding it. It doesn't mean to be complacent. That means we can't take it for granted that this is still not a problem. So the good news is that we seem to be holding, gives us a chance to get the data done, the testing, the follow-up. But we have to be vigilant, we have to be careful, we have to keep our measures up, and we have to keep doing the testing and looking for it and identifying and see if we can keep weathering this one out and to keep the amount of spread down and the impact on our healthcare system and other services such as schools and long-term care homes and retirement homes accordingly. So it's a mixed message, but do what you need to do it well and do it again. Those same measures protect, but we've got to make sure we don't step back on that and get casual as we see the numbers coming down a bit. We can be encouraged, but encouraged to keep doing the right things.
Thanks, everyone.